in the short term. And therefore, we must always be ready and prepared to enforce our containment measures and to learn to live in a new normal. We have also noted that our hospitals are recording abnormally low visitations by the sick. In ordinary circumstances, we would be delighted about this, but these are not ordinary times. And it's important to note that we know we have sick people amongst us, and we therefore urge these people to continue seeking medical assistance at our health facilities. In the coming week, we will be able to tabulate for you service delivery data that looks at hospital visits in our country, and we want to encourage Kenyans to remember, if you're unwell, you're still expected and required and encouraged to seek healthcare services from the health facility. Fellow Kenyans, our targeted testing approach is showing that this disease is now firmly within our communities. The numbers we have recorded in the initial day of the exercise confirms this. It's therefore important that in order to break the cycle of transmission within our communities, we must strictly observe the containment measures, and in particular, social distancing that we've persistently advocated for. And if we do not adhere to these measures, the disease is bound to spread quickly amongst our communities. As we informed you yesterday, we have gone to the community and have started a targeted testing approach. And yesterday, our teams were in Kawangware. And from that activity, we confirmed 7 new cases. And it's important to emphasize this. These are 7 new cases who are in the community, people who volunteered themselves to come and get tested. And so you can see this disease is actually within us, and therefore we need to ensure we adhere to our containment measures. Fellow Kenyans, in the last 24 hours, we managed to test 1,195 samples, and out of these, 24 people, and I repeat, 24 people tested positive for coronavirus. And this is the highest number of positive cases that we have recorded since we reported our first case. Out of these cases, 7 are already, as indicated, from Kawangware, and therefore this brings to total 20 cases just in Kawangware. 10 cases are from Isili, bringing the total number in this area to 21. 5 are from Mombasa, and this therefore brings the total number of Mombasa cases to 129. And the last 2 cases are from Kuria West in Migori County. And these 2 had a recent history of travel from Tanzania. The 5 cases in Mombasa are from Mikindani 2, Mwembe Tayari 2, and Shimanzi 1. And therefore, this now brings the total number of positive cases in the country to 435. The age brackets of the new cases are between 1 to 19 years of age. We have 4 cases. Between 20 to 39 years, we have 14. Between 40 to 60, we have 6. And in terms of gender, 10 are male and 14 are female. And we are saddened, greatly saddened to inform you today that we've lost 1 more patient from Mombasa. And this was a 51-year-old woman who had been admitted on the 27th of April, and she had an underlying condition. And let me take this chance to convey our heartfelt condolences to her family and her community. Therefore, our total number of fatalities now stands at 22. On a more positive note, we are delighted to inform you that we now have discharged 2 more patients, and therefore our total number of recoveries is 152. There have been concerns raised as pertaining to the situation in our quarantine facilities, and the ministry has taken note and is working to ensure that there's a comfortable stay for those who are in the quarantine facilities. And in light of the anticipated surge of numbers, and it's important we emphasize, today is the day we've recorded 24 positive cases, and we shall continue recording more positive cases. And therefore, in anticipation of this surge of numbers, we must therefore now begin a serious conversation around the issue of the quarantine system. And to this end, the Ministry of Health is reviewing home-based care, quarantine mechanisms, and we shall soon be able to issue specific guidelines as to how this shall be undertaken. And it's important to note again, the success of home-based care is highly pegged on our discipline as Kenyans and as our cooperation in terms of ensuring that we actually adhere to these guidelines. I would like to take an opportunity to thank all the individuals and corporates who continue to support this war against coronavirus. And we continue to appeal to other well-wishers to come forward and to provide support. And as I conclude again, I'd like to thank Kenyans for the cooperation, because this cooperation has made it possible for us to register some elements and some degrees of achievement, but also to reiterate that we must continue to observe these containment measures. Having recorded 24 cases is actually quite severe, fellow Kenyans, and it's really important that we continue to meet and adhere to our containment measures. And at this juncture, I'd like to invite the Director General. It has come to our attention that more information is required with regards to the care and management of our cases, and so the DG shall give a highlight on how we are taking care of our patients, what treatment measures we are putting in place, what new therapies the country is considering, and he shall also articulate on some of our resources. Karibu, DG.
Thank you, Madam CS. Good afternoon, everybody. I just want to give you a few highlights regarding the status of the patients we are taking care of as at now. As at today, we have 214 patients spread across various hospitals, of course, from the coast to the western part of the country. Out of these 214, it's only one patient who is in critical care under ventilatory support at the Kenyatta University Teaching, Research and Referral Hospital. The remaining 213 patients are in stable condition, and we are hopeful that they'll continue to do well, and therefore going forward we'll have more discharges coming from our healthcare facilities. Well, I'm sure you must have heard of the news from the United States regarding the new drug, remdesivir, for treatment of severe coronavirus disease. This is a medicine that was initially tried for Ebola virus treatment and was also used for treatment of other coronaviruses like the Middle East respiratory syndrome and the SARS, severe acute respiratory syndrome, whose outbreak was reported in 2003 in Hong Kong. This medicine, a trial was done in the United States involving 1,063 cases, and this was a good trial because the caseload was good, more than 1,000 people, and the primary endpoint was the recovery in terms of either stoppage of use of supplemental oxygen for critically ill patients or the time for discharge. And during this study, 31% of the 1,063 people were able to go home within 11 days, compared to the other arm who received the normal treatment. Based on this, the Federal Drug Administration Authority in U.S. has decided to register this medicine for treatment of coronavirus disease 19. However, this is not to point out that now we have a cure, because if you look at the time frame, it's only 15 days for those who receive normal treatment versus 11 days for those who receive remdesivir. Therefore, this is not a silver bullet, though it has been approved, but the other shortcoming of this medication is that it can only be given as an infusion through an injection, so there's no oral formulation, and is also relatively expensive. For our cases, because most of our cases are mild asymptomatic cases, it could be deployed, but to a small fraction of our patients. Of course, we still continue to pursue the use of other medications, including favipiravir, also called Avigan from Japan, the antiretroviral medicines that have been tried, that is lopinavir, ritonavir, or Kaletra, as commonly known, the use of chloroquine, hydrochloroquine, which again has also been prioritized by the U.S. government. And of course, is now available locally in case we need to deploy it for our patients. So that is in terms of the treatment landscape, how it looks like. Still no cure, despite this encouraging news. For testing, you have heard of this case of Senegal where they used the rapid test kits. And the rapid test kits from Senegal are based on antibodies. Antibodies are basically proteins that our bodies produce in response to an insult or an antigen or a foreign body. And the first antibody that your body produces if you get exposed to a virus, say measles or COVID-19, is called IgM. The second antibody, which is produced much later after usually 2 weeks or before, is called IgG. So the one of Senegal is based on IgM. But the pitfalls of these rapid test kits is because, one, you tend to produce the antibodies after about 2 weeks. Therefore, you lose significant opportunity of 14 days where you could be able to trace, isolate, and quarantine people, and therefore stop further transmission of the infection. So that is one big limitation of the rapid test kits. Number two, the rapid test kits are not selective. There are very many groups of, very many types of coronaviruses. So even if you have the coronavirus that causes a mild cold, the rapid kit could interpret it as COVID-19. That is what we call in science a false positive. And therefore, you will be diagnosed as coronavirus disease 19 positive, yet you have the simple corona that causes a cold. Number three is that if you are immunosuppressed, like if you have HIV infection, or you are malnourished, or you have a serious infection like TB, your immune response is subdued, and therefore you tend to produce less antibodies or no antibodies at all. In that case, if you put you through that test, it will come out negative, yet you could be positive for COVID-19. And finally, regarding the rapid test kits, is because even if you have the antibodies, evidence has not shown that those antibodies will protect you from reinfection. However, these are good diagnostic equipment that can be used for research purposes, like in KEMRI, and also for carrying out what we call seroprevalence surveys, or you want to find out the spread or the incidence of a disease in a community, or the prevalence of a disease in a big community. I also wanted to emphasize a bit on the cases from Kawangware, as Madam CS has alluded to. There are 20 cases from Kawangware. 12 of these cases can be traced back to one single individual. And this single individual used to work with us at the Emergency Operations Center. This single individual passed the infection over to 6 primary contacts. Out of these primary contacts, there are 5 secondary contacts. So if you draw that tree, there are 12 people linked to this particular case. If you look at the case of Kilifi, the index case had 5 primary contacts, 1 secondary contact, and 1 tertiary contact. And of course, we continue to do surveillance because the 14 days mandatory period for incubation has already passed. So you cannot be able to tell how many people one person can be able to pass the infection to. And why am I saying this? Because this is important, because then it is the reason that we talk about quarantine and isolation. That quickly, if we test you, we need to move you into the isolation unit so that you don't stop going these branches. And for those who test positive, of course, we also move you to the isolation site. The others who have not been tested, of course, are kept in quarantine, therefore trying to stop the transmission. And that is basically what leads to a flattening of the curve. Finally, I wanted to share with you the donation that we received from one of our many partners who have supported the ministry. One is the Jack Ma Foundation. I have a table here with me regarding the quantities of whatever was donated, what has been distributed, and what is still in stock in our KEMSA stores. Like, for example, the test kits were a total of 208. If you multiply that by 80, you get about 17,000 test kits. Remember, if you test you and you test positive, at a minimum, you will require 3 tests at a minimum. The first test, the index test, that determines whether you are positive or negative. If you are positive, then you require another second test after 14 days. If that test is negative, you will require another test after 24 to 48 hours. So if you divide this number of kits by 3 on average, then you find that we had about 5,000 to 6,000 test kits. And therefore, anytime we report that we have a given number of test kits, remember each individual at a minimum will require 3 tests. So always divide it by a minimum of 3. Of course, we also received viral transport media, 18,900 pieces, all which have gone to various laboratories, various face masks which have all been distributed, medical disposable protective clothing, 1,100 pieces distributed. I can be able to share this with you. So in a nutshell, based on what I've been able to share with you, is that we are not out of the woods yet. We expect a surge in our numbers as we continue with the targeted testing. And therefore, it means we require more quarantine facility, and that is why Madam CAS has clearly articulated that we need to look at our quarantine policy, because the numbers soon will be huge, and possibly look at even home-based care. Thank you.
Yeah, just questions.
Madam CS, you just mentioned that, okay, you raised concern about people actually returning back to their normal business in the country. But the same government is now telling people, particularly in Kawangware and the areas where mass testing is actually being conducted, to actually turn out in large numbers. This is a process that is actually being done in an open air place. And I was in Kawangware where some of your awareness people were telling the Kenyans that, okay, this virus stays in the air for about 3 hours. So if at all you cough, and it finds you maybe in such kind of a scenario, you're likely to get infected. Some people are actually traveling all the way from Kasarani pipeline to go to Kawangware for the mass testing. How secure are people who are undergoing for this mass testing?
And still on Kawangware, the Interior Principal Secretary, Dr. Karanja Kibicho, had mentioned that mapping out was being done of estates that have seen an exponential rise in the number of infections, and they would be mapped out for more stringent measures, including possible lockdown. Maybe has this been considered for even an area like Kawangware, which is a densely populated area, including Isli? And maybe you can also touch on the fact that we've seen since the mass testing began in Kibokoni and even Old Town Mombasa and even parts of Nairobi, initially there seemed to be low people turning up. Maybe there's the stigma associated with COVID-19 and even the possibility that one will fear being put in quarantine and cater for that particular cause. So maybe what is being done to ensure members of the public see this as an initiative that will help the country maybe turn up for testing.
My name is... There are rising cases of, we've seen the rising cases of coronavirus in Tanzania. Is this a concern now to Kenya? Because we've seen our neighbors, Uganda, have recently reacted towards their response. And has the Kenyan government now been in communication with the Tanzanian government regarding the matter? My second question is regarding the 51-year-old lady who passed on in Mombasa. So our sources tell us that the lady was an employee of Central Bank in Mombasa, and her children are right now in quarantine. Could this mean that this is a threat for everyone who works at the Central Bank in Mombasa? And my third question to you is, are the cartels in the ministry fighting or hindering the fight against the pandemic against corona as well?
Purity myself from KBC. You talked, the DG, you talked about a new drug which has been approved in the U.S. We do understand that U.S. has the highest number of coronavirus cases in the world and also deaths. Is there proof that the recoveries that were confirmed in the U.S. were as a result of the administration of the drug, or it could be, it was just immunity, the immunity that was high? And then to the CAS, when you talk about some people being picked by the surveillance team. What exactly do you mean? Do they randomly walk and test people on the streets, or being picked by surveillance team? Because when you've been making the updates, some numbers you say that they are picked from by surveillance team. Probably you can expound on that.
Okay, thank you. Thank you for those questions. I think I'll start with Purity's question on surveillance. There is actually a scientific methodology that is employed when you're doing contact tracing. Yesterday, the Cabinet Secretary was able to share with you in one of the slide presentations what contact tracing would look like. Hypothetically, say you have case number 2, and that you've confirmed that case number 2 is positive. There's actually a mechanism that we deploy where case number 2 undergoes a history-taking procedure, and we're able to map out the patterns of movement and contacts of case number 2. When that history is taken, this is uploaded on a database, and then the cases and a branch, diagram is drawn, and the next primary contacts of this case are then investigated. And this goes on and on and on until you're able to pull in the contacts, the primary contacts of this case, and you're able to test them and confirm them. If you remember when the DG was expounding on some of the models that we were discussing much earlier, some of the assumptions that actually go into the modeling are pegged on how you do your contact tracing. And so it's actually a methodology that is done. We're not simply running around and picking people on the street. There's actually a science behind how that is done. With regard to the question from Chemutai on mapping out of estates, again, yesterday and even in previous briefings, we've been able to share with you areas that we consider to be hotspots and clusters. And again, this is information that is generated from our contact tracing and from our surveillance activities. And indeed, you've seen the world over, different countries have gone on and employed different methods. Some have gone on to impose partial or full lockdowns in different hotspots. This is an issue that will be under discussion tomorrow in the NERC, and we shall be able to relay with you the following interventions after that discussion tomorrow. Again, there's a question with regard to stigma. I think last week we highlighted it, and we've received lots of calls and messages from Wananchi trying to, share their experiences in terms of stigma. I think we shared with you our case of an ICU recovery case who has actually struggled to be assimilated back into the community. We are looking at revamping our communications, looking to have champions, people who've recovered from corona, who can actually share their message and their experience and tell us that this is something that we are actually able to combat. But that being said, we are looking at adding more approaches, trying to see how we can actually incentivize Kenyans to come forward. Tomorrow again at the NERC, we'll look and see, are there measures we can put in place to encourage people to come and test? Are there measures we can put in place to ensure that quarantine perhaps is not at a high cost to Mwananchi? And so all this will be discussed tomorrow and shared with you after the NERC meeting tomorrow. There's a question from Kaemba with regard to returning back to business. And people perhaps, it's looking like it's a paradox when it comes to the containment measures. I think several times we reiterated and said that even as we, for example, reopen hotels, containment measures must be put in place. As people go to the barbers, you must ensure that you're masked. As you go back to work, you must ensure that your surfaces are sanitized. And this is essentially what we are saying, especially in light and in view that coronavirus might be here with us for a long time. Like I've said, this is not a sprint. This is a marathon. And therefore, balancing the merits of ensuring that we put in place containment measures that protect us and ensure an element of economic continuity, it's important then that Kenyans work with us. Like I mentioned, we've been doing random checks. I myself was in Kawangware just the other day, and I could see people with masks, but their masks are hanging by their noses. I could see sanitizer, but sanitizer did not look like it was being utilized. The bottle was quite full, and people were just passing around it. And what we're saying is, if Kenyans can work hand in hand with us, of course we want to go back to normal. Of course we want the economy reignited, but we have to also protect the countrymen. And this therefore means we have to work together and enforce these containment measures while trying to come to a new normal. There's a question concerning Tanzania. And the rising cases, and I think this has even been highlighted in our brief today. One of our cases today is actually a contact who had come in traveling from Tanzania. And as you all know, Kenya is part of the East African community, and therefore there are discussions with our different member states to be able to come up with mechanisms that actually enforce good screening procedures at the border. And yesterday the CS was able to highlight some of these measures. Discussions have been held and agreements have been made in terms of how we can ensure cross-border travel is going on in a manner where screening is effected and we're actually ensuring we're protecting EAC as a community. There's been a question again regarding our case, the lady who passed on. I hesitate to provide details because, again, you must remember, this is still a medical case and we are confined in terms of disclosing details of this particular patient. However, what we are saying, if you can all actually tabulate up to our case today, our caseload being, more than 400 today, all these are people, most of them who've had contact, other than our imported cases, who've been in the community. So narrowing this down to central bank is actually quite misguided on our part. These are Kenyans who've been in different areas in the community, in supermarkets, perhaps even brushed across you as you're walking in the street. The idea here is, and the resounding message here is containment and adherence to social distancing measures. Perhaps the last question before I hand over back to the DG, just to emphasize on contact tracing, because I think clarity is required, more clarity is required there. There's a question on cartels in Afya House hampering the fight for coronavirus. This is an issue that our Cabinet Secretary has clearly elaborated on, and he continues to be a steward within the ministry, ensuring that he actually ensures that there's accountability and efficiency as we deploy resources towards coronavirus, but also resources for many other interventions. Remember, this is not a ministry of coronavirus. This is actually the Ministry of Health, and there are many other diseases and conditions that we deal with. And therefore, the CES and his team, his leadership team, are ensuring that there's efficiency in deployment of all resources. Bwana DG, perhaps highlight further what it means to actually do contact tracing and the issue of Kawangware.
Thank you, Madam CS. I think she has articulated very well the science of contact tracing, and that is how we are able to build this tree of Kawangware and Kilifi. And based on that, of course, the subsequent measures that we take, including the quarantine and, of course, the positive cases, moving to the isolation centers. But together with that, of course, we will not tire from reminding you of the infection prevention control measures, including the hand washing, the use of the sanitizers, the physical and social distancing, and of course, proper use of masks. And I want to support Madam CAS. Kenyans now have this tendency of wearing their masks on their chin. I don't know why then. Why would you put it on your chin? I would rather, if you don't want to wear it, then don't wear it, so that then the security guys can be able to deal with you. Because you put it on your chin, then you put it back on your face, you contaminate yourself, and you put yourself at a greater risk of contracting the disease. Regarding the trial in the US, this was what we call a randomized controlled trial, where you have one arm of people receiving a particular treatment, in this case, this particular medicine, remdesivir, and the other arm would receive their normal treatment. And the first primary endpoint was either stoppage of use of supplemental oxygen or discharge at home. And that was clearly elucidated by 31% of the people who are receiving the drug, either stopping use of oxygen early by day 11 or them being discharged by day 11. The secondary endpoint for this study was, of course, mortality, and that data is being analyzed. So I cannot clearly state before you today that remdesivir actually decreases mortality or deaths. And that is why I said in my statement that it is not a silver bullet. Let me also just highlight something small regarding the hotels. When we said that the hotels open, we developed clear policies, guidelines, and protocols to be used. And when we opened hotels and restaurants, we didn't blow the whistle for people to now go and congregate in hotels and restaurants to go and partake their meals. Instead, we really want the hotels and restaurants still to focus more on takeaways. And this is because as we are going to open the hotels, we are also going to talk of this testing, which will include a financial cost. And because our guidelines clearly indicate that primarily if before you had, for example, like 40, you could seat 40 people at full capacity. In the revised guidelines, you could be able to seat just about 8 to 10 people. So it means you'll have also to reduce your staff numbers. And therefore, if you reduce your staff numbers, it makes business sense to focus more on takeaway than people seated there to be served. We are going to do random inspection to ensure that all hotels and restaurants apply to the letter the guidelines and protocols that we have developed. And if you are found flouting any of these guidelines and protocols, one penalty, of course, will be closure. Then the secondary penalty, of course, will be prosecution under the Public Health Act, Cap 242. If we continue with our journey the way we have journeyed this far, and following our presentation yesterday, we could be able to flatten the curve. If you looked at one of the slides was really presented yesterday. However, if we think that things are okay and we are back to normal, the Republic of Ghana today, after removal of the lockdown, has noticed a more than 40% upswing in number of cases, and we are not immune to that. Thank you.
I think.
No, I think I'll answer.
Na bila shaka mtazamaji, ni picha za moja kwa moja hapo kutoka Wizara ya Afya, ambapo dakika chache zilizopita tumeona Daktari Mercy Mwangangi, mratibu katika Wizara ya Afya, pamoja na Patrick Kamoth ambaye ni kaimu mkurugenzi katika Wizara hiyo ya Afya, wakitoa taarifa ya pamoja, taarifa ya kila siku kuhusiana na maambukizi ya virusi vya corona, hali ilivyo mwezi huu wa Mei, mtazamaji, ambapo tunaona kwamba inajiri siku chache. Tunajua kwamba kwa sasa tayari mchakato mzima wa kuwapima wananchi katika maeneo mbalimbali umeng'oa nanga rasmi katika maeneo ya Kawangware na vile vile katika kaunti ya Mombasa, mtazamaji, tukiripotiwa kwamba kufikia sasa kuna idadi ama maambukizi mapya ambayo yamefika 24, visa 24 vya watu ambao wamepatikana kuwa na virusi